Good morning, everybody. It's always nice to talk when you don't have to hold a mic and people can still listen to you. So I'm Prashant and I'm from Surat. Like, it's known for its food and it shows in my size too. So just one hint. What I'm going to be talking about is screening of diseases and bad obstetric history. This is something where I think we are a triad of people: a gynec, a sonologist, and a pathologist. And eventually, this is something where I feel we have to be sensitive about this. This is one photo which I came across, and that story was quite painstaking, where the womb has borne these 4 children, but it hasn't been able to conceive. This agony which is there is something which we have to look upon. While I was searching for it, I came across this nice quote like, "A wife who loses a husband is a widow, husband who loses a wife is a widower, a child who loses a parent is an orphan." But there's no word for a parent who loses a child. And that's how awful this loss is, plus the social stigma associated with it. For me as a doctor, more than a pathologist, I think BOH would stand for being optimistic healers. Because we have to flow in that optimism with our adequate knowledge, the kind of clinical information we have, and the fact that BOH is something which in quite a few cases, say from 40 to 60%, is actually treatable, reversible, and we can give the child, a mother, a smile on the face. When we use the word BOH, we use it loosely for patients in whom the obstetrical feature is likely to be modified by the nature of the previous disaster. It's not the first time when somebody aborts or there's a miscarriage that we start labeling it as a BOH. The WHO definition, again, it's a fetal outcome of 2 or more. Now, with all the anomalies, and the anomalies will be spoken up about, like Soumya Madam will be talking about it, and at the same time the radiology part will be taken care separately. Now, what can be construed as BOH? Now, when we use this word, because whenever we come across, as a pathologist, we often get a clinical diagnosis as BOH when there's a whole battery of investigations. And at these times, I think as a lab, you have to create your protocols, especially when higher end tests in citrate, like say protein C, protein S, all of these are also asked for. So the history, all of these medications, that's why I always feel the clinician should always give us a hint, like why are they asking these tests? Normally we encounter thrombophilia, otherwise also in young patients, but here the patients are young, they look fit, and yet they come up with this. So when you have a BOH history, so we take more care on it. Now, these that are mentioned, an important part is that there is a neonatal loss due to non-obstetric reasons, like say diarrhea, fever, which is very common in our country. And viral illnesses, recently, I think 4 or 5 years back, even with dengue, we had seen patients, being treated just because of the low platelets and mildly elevated SGPTs. There were some guys who attended fancy conferences and thought that this is help or something. So we have to be very clear about the kind of disease we are treating, dealing with. What do we do about it? A detailed obstetric history and a patient hearing is needed. Now, on the clinical side, I do believe you have to be patient. Like in Surat, we have 2 gynecs who particularly give them a different time. So they usually don't see these patients during the rush hours. So if they're going to see them, just look, it's quite a scary device. Okay, so in Surat, for example, I am aware of 2 senior gynecs who give a different time slot whenever they have such patients, and they see to it that they spend adequate time with them. And particularly in that room, he's removed all the photographs of all children and things which could unnecessarily torment the mother. So again, on our end also, these are small things, but I think they are vital. Then the review of all the medical information, and at the same time putting up a management plan and modifying the risk of the disease. Now, after knowing what we have to do about it, we have to keep in mind BOH does not often have a single cause of concern. It's like a battery which is fighting from all ends, like an army rather. So identify the cause if possible, and half your battle is won. Close monitoring and teaming up with your sonologist and pathologist yields in better outcome. Now the recurrence suggests a persistent cause. And it's not just a bad omen or bad luck, because in our country often when the good happens, people blame, thank God. But when the bad happens, they blame the doctor. So we have to make them understand and see to that we don't give them any assurity. Like in this new age, everything is 100% guaranteed. I think that's one thing we should avoid doing. And this needs to be identified and it has to be treated. Now, what are the causes? I think the causes ma'am is going to talk about, so I won't go into all of these numerically because they'll be coming in my subsequent investigative part also. Now, when do we start investigating? Now, this is a big $1 million question because finally these tests are going to be expensive. There's no guarantee at the same time. So, if the patients often feel, I remember years back, a patient asked, he had a B12 report and I just gave a one-liner. So he comes back after a while and says, sir, I spent 500 on this test and I just got one line. In urine, I spent 50 rupees and I get a full page. So we are still an economy which runs on sizing. So that time the only answer which luckily my dad gave him was, कि 100 रुपए का इतना गोल्ड आता है और इतना कॉटन आता है, ये तुम्हारा गोल्ड का टेस्ट है. And the patient felt happy and left. So I've copy pasted that answer and I'm sharing it with you. So ideally we do these tests after 3 losses. But earlier, if a high risk patient is there, elderly patient is there, there's a defined medical history, a known family history, and particularly the VIP syndrome, where even we have to be quite careful. It's always better to start with the commoner tests, and ma'am will be talking about that, rather than jumping into the entire battery. We often see, like in Surat, when we send a patient across to Mumbai, so then they start valuing us more because here they've spent 25,000 on investigation, and 2,500 in Surat they would find us expensive. So this is one small difference. Now the laboratory investigations, I can't make a list of what all we should do, but broadly speaking, I think one of the first ones should be a CBC. Then the thyroid function test, the diabetes check, the hormonal profiling, which I'll be talking about separately. Because in hormones, I just don't want you to feel it's FSH, prolactin, like we typically, stereotypically type out. Anticardiolupins, lupus anticoagulants, and that too with lupus, I feel that it should be very clear that we are doing 2 types of lupuses. That's the LA1 and the LA2, because that's the dextrin-ecitrin ratio which we come across, and with excess phospholipids, we get excellent results. So that's something which, because now a lot of people earlier used to do the KCT and all, but I would say now the time has come when we've got far better kits and we can get much better results. Simple tests like VDRL, torch, there's a big question mark. Surprisingly, torch normally shows the light, but here it's more confusing as a test, even as a parameter. And while I was reading it up, and even if you search out on the Cochrane database, there's one group which says yes, one group says no. But then what I've done here today is I've taken up the Foxy statement, which was quite recent, and I think what they have said, I have simply copy-pasted, because I think let's Indianize our whole treatment protocol. Then the thrombophilia screen, which is vital, especially on the 2nd, 3rd loss. And of course, everybody talks about karyotyping, but going in for karyotype from the first time, I think it's a little insane. We just can't attribute everything to a bad gene. Now, I want to talk about one thing which is most common, especially even in our country, preeclampsia. Usually, the signs and symptoms, I'm really not keen to talk about it, because ma'am will. But then, on your end, even as a clinician, because I always feel pathology and radiology, we are still consultant radiologists and consultant pathologists. So we are clinicians too. Now the problem is in this fly-by-night operator system, people feel a lab is just there to, give a report, sample uthao, report bhejo, email. So that's not the way it is. That interaction helps us a lot particularly. Now, for example, even weight gain, edema, etc. Now on this front with proteinuria, I think one important finding is whenever, like a lot of gynecologists have this dipstick method of checking urine protein in their OPDs. like at least it's prominent in, say, the medical colleges, in like outlays the civil hospital. So when you have more than 1 plus, which expresses on a qualitative estimation, do ask for the 24-hour urine. Now we can even do a spot urine protein. So 300 milligrams per liter or more, and then a protein creatinine ratio of more than or equal to 0.3. This is also quite handy. Now the prediction. The fun part is if we can predict preeclampsia, because we all know how lethal and fatal preeclampsia can be. Now on the clinical side, I say ever since we were in postgraduates, the simple rollover test is there. Then urine calcium is often underutilized. Many people just don't know how to use it well. But then anything less than or equal to 12 milligrams per deciliter in a 24-hour collection is one hint that you're proceeding towards preeclampsia. Same holds true for the calcium creatinine ratio, which is usually less than 0.06. In the angiotensin stress test, again, expensive, just don't jump into it. Plasma fibronectin, I think there was a lot talked about it, that will increase and all. Then we saw that especially in obese patients, in patients who were already on lipid-lowering drugs, especially in the elderly when we used to face them, it really doesn't help. Dopplers, I think, still are the best one. Okay, so that's one part. Now there are 2 new tests on the horizon, and normally we always talk about a double marker and a triple marker, but these go one up, and these are the dual marker plus, and for the second trimester we have the preeclampsia ratio. What I'm now going to talk about is something which is comparatively new, and it's more of an excellent predictive marker for preeclampsia. Now, what are these 2 tests? We all know that in first trimester we do the dual marker, second trimester we do the triple marker, and then we have the quadruple marker also. But here we are using it not only for the trisomies, we can even predict preeclampsia, and this can be a lifesaver. What's the difference? With the dual marker plus, on the dual marker we used to have PAPA, that is the pregnancy associated plasma protein A, and we used to have free beta HCG. But here we have an additional parameter, which is the placental growth factor, that is PIGF, PIGF. Now, the same thing is for the second trimester, where there is a preeclampsia ratio. Now, when you have patients who are suddenly becoming puffy, they start looking huger, there's edema, there's normal urine protein, everything. So, and they have a strong family history. Or she ever says that, yeah, she once had a bout of hypertension, she took a simple drug and it was cured. Here this ratio helps a lot. That is the FLT1 and PIGF ratio. Now, ever since FLT1 has come in, that's the soluble FMS like tyrosine kinase. Now, some of you who do cancer work, you've seen tyrosine kinase in case of AML-M3s, where we've got excellent drugs now. But here, this thing, it picks onto the soluble Fraskin ratio, and what we get is a ratio based on which you can start predicting preeclampsia very effectively. Now, the indications, particularly here, I'm not going to talk about the trisomy part, but it's an excellent marker where you can start predicting the risk of preeclampsia, and that too in the absence of any clinical signs or symptoms. This is where it helps a lot. So normally when you have a history, this is a loaded family, khate peete garke, mother hypertensive, father hypertensive, husband ho, so it doesn't make a difference, I guess. But then at least these guys are all hypertensive, and it's a VIP patient. Definitely do think of asking for this test. They will feel like you are now the new astrology in the family. Then the second trimester, particularly like obese, now we see a lot of women smoking. Like for Mumbaikars, it's a very common thing. We guys still get some shocks. Like kal raat ko when I saw dabadav, I said, okay, these are some, preeclamptic women on the rise. Okay, sorry if anyone smokes here. Then the first trimester dual marker plus again. Why the interpretation is important is simple low dose aspirin. It virtually works wonders, especially when the patient is under 16 weeks. Now imagine aspirin to stop hypertension. This is as good as the physicians kicking me out of this universe. But all the studies, especially the ESPER study, the trial clearly indicates that we have almost 50 to 80% reduction in the onset of preeclampsia. And I think that is worth the money. And it's a 4,000 rupee test. It's not even that expensive. Now, with the FLIT and PGIF ratio, again, we have two outcomes. One is less than 37 weeks and one is less than 34 weeks. That's the early onset and the late onset. Here, what we have to keep a tab on is ratios of either it's less than 38, so we rule out preeclampsia. Now, this KIT protocol says for a week. Now, that's something which even I find funny, that it's normal only for a week, they're trying to say. Then the second part is whether it's between 35 and 85. So follow-up test is needed, especially in that gray zone. If it's more than 85, it's usually preeclampsia. And admission of the patient along with close monitoring. So you can advise bed rest and, tell her to come for more frequent checkups. And if it is more than 655, which is defined, and we've seen plenty of cases now, delivery within 48 hours is advisable. And this is where high standard ICUs like the NICUs now, they play a big role, because these are very small kids which are delivered. Now, and here again, prompt initiation with antenatal corticosteroids is very much advisable in these cases. Now, again, with higher ratios, and especially now less than 37 weeks, the same thing, but the cutoffs are different. Here it's 38 to 110, and more than 201 is usually, it warrants that the patient should be prompted and told that this is now urgent. Endocrine factors, we all know about diabetes mellitus and what havoc it can cause otherwise. And ma'am is going to be talking about it, so I'm not going to go into the details of these. But then on the screening part, or as a lab, the investigations are split up into 2-3 areas. One is screening for gestational diabetes mellitus. And one myth which I've often seen is the patients are told that you have to go on a fasting state, especially when we take the 50-gram load dose. I think that's one myth that should be cleared very clearly, that 50 grams can be given, so the patient can walk in at any given time. And 50-gram glucose is given orally, and what we do is we let the patient sit there for an hour. We just, even if they want to go out, we tell them not to climb stairs and do something which is like rigorous. So, and if it is more than 140 milligram per deciliter, after 1 hour, then you can definitely consider that this patient is warranted a GTT. And if it's more than 200 milligrams, it is definitely going to be a diabetic. Now, certain people have put HbA1c2, that is glycosylated hemoglobin, of more than 8. But then I couldn't find records which would tangibly say like, yes, this is a fact. So monitor your HbA1c later, and I think a target of less than 6 would be good enough. Now, this is with the 50-gram glucose. Now, with a 3-hour GTT during pregnancy, this is after 100 grams of glucose. And secondly, now with 50 and 100, there's another thing to take care of. Certain labs, they carry those 500 gram packs because they're cheaper. And just like our mother does masala, like normally if I would read a talla dalal, I'll read 5 grams, or measure 5, add 5. But our mom will just do something and it happens. So these labs often tend to, pour it into a glass and consider it's 100. I think that's something that should be avoided. They can charge 10 rupees more, but they should take those exact quotients when it comes to the final volume. Now comes the 75 gram oral glucose, which we all know about since eons. Now here it's the same cutoff on fasting. Less than 100 to 126 is impaired, and more than 126 on 2 occasions is diabetes mellitus. Always keep in mind 2 occasions is important, because sometimes the white collar slurp which you get is not only in hypertension, but you'll see it in these borderline cases also. Then on the endocrine factors, after diabetes, an important thing is thyroid. Actually speaking, this is one place where I think a TSH would suffice. But since we all used to T3, T4 TSH or something, if you have to ask for it, ask for a free T3, free T4 TSH instead of just a T3, T4, TSH, or like you can ask for the thyroid 5, which covers the entire spectrum. And then another important thing is the antibodies, which is TPO and TG. Now, again, here there is this kind of controversy where a school of thought believes like it's not a cause of recurrent, miscarriages. So again, barring this confusion, I think Madam would help us out, like whether TPO or TG has clinical significance. And especially in cord blood, I would prefer that you ask for free T4 and TSH, because instead of taking venous blood or sending us arterial blood from the neonate, like as soon as it's clamped, you could send us cord blood too, because we have reference ranges which are defined for cord blood. Now, an important thing is Pcos. Now, with the Achhe Din coming in, hopefully, whenever they do, this is going to be something which is still going to increase. And now, even with whatever din we have, we do see characters like me moving around freely. So, this is an area of concern, and normally, whenever we talk, we've been talking about insulin as a whole. But now I think it's time that we should know insulin resistance, simple tests like fasting blood sugar, insulin. Then we have hyperinsulinemia, which is again, you're doing your insulin, you can do a fasting, you can do a PP. And there are some gynects who go for 1 hour, 2 hour, 3 hour. Though I don't give them values for 3 hour and for 1 hour, but I still get them. And an excellent test which I would always recommend now is the Free Androgen Index, FAI. This is something which is really, it's an excellent marker when it comes to prognostication for subsequent miscarriages. There is a simple calculation. It's 100 multiplied by the testosterone value divided by the sex hormone binding globulin, that's SHBG. So FAI is something which we find very effective, and in females the reference range is 7 to 10. We use it even in males. So there it's a little higher, it's around 40 to 82. So here there's one take home, that's FAI. And like earlier when we started doing this test around 6-7 years back, so when you can't remember phi, remember Pcos and all is fat. So T ke bajay I laga do, so that's your. Now another important thing, or rather something which we often find helpful, is the evaluation of the ovarian reserve. FSH concentrations on day 3, once you start measuring them, it helps a lot during all of these RPLs in women of any age. Now, one interesting finding that we often see is, statistically it's there, but we see it in our patients too, that in a lot of these patients on day 3, FSH is increased, and some of these, our old-time gynects and these IVF guys, they often ask for E2. So I used to wonder, why are they asking E2 over here? Because clinically it wasn't setting in. Like, especially when you're investigating BOH. Then now I feel like estradiol over here, it's working out, E3, sorry. So they go for E2, E3 and FSH. And when they're elevated, it's again a good marker of ovarian reserve. Now we have AMH, so we guys jump. See, usually what happens, estradiol and FSH, both of them are seen to be quite high. Yeah. Another important thing which I feel, why I'm discussing this here now, is we have a lot of therapy going on where progesterone is given left, right, center. I was just talking to Madam about the same, like though there aren't any clear-cut studies, but I think the sale of progesterone is quite phenomenal when it comes to clearing the endometrium. So the luteal phase defect and the progesterone deficiency is something that all of you should be aware of. A functional corpus luteum is essential primarily for successful implantation and the maintenance of an early pregnancy. And this is why I've purposely put this under the endocrine factors. Though no evidence has been found in literature, and because now all of a sudden anti-Mullerian hormone requests have started coming in. But I don't see the role when it comes to this cadre of patients. And secondly, whenever you have a luteal defect, don't unnecessarily go for an endometrial biopsy. It just increases the stigma and increases the hope of the patient. But here the interesting part would be, because of the defect, there will always be insufficient progesterone production. An area where I've purposely moved out all the clinical parts, because normally as a pathologist I'm supposed to do the tests. I don't usually ask for them, but then this is not going to be for the first time a patient has a history of a miscarriage. And what we are talking about is acquired, where we have the antiphospholipid antibody syndrome, and the inherited, where this whole battery of tests, protein C, protein S deficiencies, antithrombin 3, activated protein C, the PT gene mutation study, and most importantly, I would put first is hyperhomocystinemia. Because somehow, somewhere, and it's not that because you're a vegetarian you get it, there's a lot of stuff, and people believe, there was this old school of thought, they thought if we have supplements of B12, homocysteine automatically gets corrected. But I think they missed out that chapter in biochemistry or pathophysiology where a methylcobalamin pathway is being bypassed. And the biggest problem with homocysteine when it increases is the endothelial dysfunction it causes. That's why even in cardiac patients and even here, we find that on quite an increase. APLA, to diagnose it, what I want to actually put across, and which is very important, is 2 positive tests at least 6 to 8 weeks apart for ACA as well as LA. Now the new test which has come in is, I can't call it new, it's 4-5 years old. Like it's anti-beta 1 glycoprotein, IgG, IgM. So we find that very effective along with cardiolipins. So with beta 2, sorry. So that is something which is again in. But I'm stressing out on the fact 2 positive tests at least 6 to 8 weeks apart. The British say 12, but we don't have that much time because, and usually doctors would start treating from the first time itself. So I would Indianize it and say at least 2 weeks apart. That is vital. And if the titers are intermediate, don't go for the ACA. But if it's more than 40, definitely it warrants therapy. On lupus anticoagulants, there's this whole protocol, and there was a school of thought only if APTT is raised, then we should proceed. But those days are now gone, because now with diluted Russell Viper, that is the DRVT, we have excellent correlation because of the excess of phospholipids which are ingrained into those products. And what we get is a LA1, we get a LA2, and we get a ratio. If that ratio is more than 1.3, it definitely warrants the fact that this patient is of lupus, and be wary of it. Since we have cheap treatment, easy follow-up, and great results, this is something where a patient shouldn't pay a price because of our folly. These are the expensive, Soot Boot Ki Sarkar jaise tests, and all of them together they're quite expensive. But incident-wise, if we look at protein C, protein S, and antithrombin 3, I think we have to be, put up the bells for the patient, like be very careful. And usually we will find that there will be a family history, a bua, a mother, a sister, etc. also who will fall in the same bracket. Now the interesting part with antithrombin 3 is it's a very strong acute phase reactant also. So with infections, especially in our setup, we often find an elevated one. So don't go by those numbers when you see an antithrombin 3 value. Infections, very common. There is a controversy, but chiefly I think bacterial vaginosis, something that you should be, and particularly whenever you do a proper per speculum examination, in posterior fornix, the gynecs normally take a very good swab and send it across. And very easy to treat with clindamycin, and it does very well. In our country, genital tuberculosis, again a big issue, and one of the biggest causes of implantation failure. We often tend to not look at it, and now even Achhe Gharo Ki Ladki and all that, I think it doesn't work because it is there. Syphilis should not be missed out. So simple VDRL should be part of your antenatal profile from the beginning itself. Torch, I really don't know what to say, because saying something, that too when I'm being recorded, would get me in a fix. But then I've safely used what the Foxy statement was. Like, they firmly believe that routine universal screening, that is the full torch panel, is not recommended in asymptomatic pregnant women. That is important. Because we also used to torch IgG, IgM, that's how we are going. But here, what I want to lay, particularly push some buttons about is, And surprisingly for torch, the Foxy also talks about it, they're talking about parvovirus 2, and at the same time they're talking about HIV, HBsAg, and HEV. So that's something which I actually would like to ask, like, why these guys? In pregnancy, yes, HEV I always consider it very lethal. And for some of you who might not know, HEV per se just has a 0.4% chance of mortality. But if a female is pregnant, that rises to almost 40%. So there, that's one indolent virus which becomes very lethal. So, and then what they've said, again, this is the Foxy statement, if you're suspecting these 3 cases, fetal hydrops, fetal brain lesions, unexplained IUGR, or other sonographic markers of fetal infection, then only ask for the torch test. Now what happens, so here I've just mentioned the parvovirus B19 also, which has been included. Now here there's an interesting thing. Whenever you look at CMV, and then you have brand ambassadors like Amitabh Bachchan talking about rubella, measles, so a lot of women have high titers of IgG. So we often, in the old school of thought, IgG, so it's protective. But now be careful, that's a statement which has become very loose. And how do we save ourselves from those loose statements? If it's a very high thing, there's a test called avidity. Now avidity turns out to be one very interesting part where we first see the response of the IgG that is formed. And just taking home the point, here, a high avidity would mean an infection before 3 months. And a low avidity would mean an infection within 3 months. So you will have CMV IgG which is high. So you can't just stamp it that, okay, you're now protected. Here your avidity is going to tell you, like, if it's a low one, this is a recent infection. And if it's high, it's been there. And that's why the avidity test is there for CMV, it's there for rubella, and we find it to be quite a good marker. Not asked much, so what I do now is I outsource it because I have the machine to run it, but then I can't fulfill that pricing. Something that we should all know about is natural killer cells are being talked about left, right, center. But here, why I purposely put up across this, I've used uterine natural killer cells. This is UNK. Normally, our natural killer cells, which we see in the peripheral blood, and the uterine natural killer cells are actually 2 distinctly different entities. So I still don't realize why people are so obsessed to ask for the T subset and natural killer cell profile. If you really want to ask, an interesting profile is the GCSF, because now the GCSF cytokine is actually turning out, like, 2 studies are parallelly going on, one in Germany and one in Ireland, and both of them are showing that deficiency in pregnancy adversely impacts the placental development and fetal growth too. Karyotyping. We all, so once a patient has gone through this entire battery of tests, this is one thing that's particularly, it becomes the first line of testing if it has already been 3 miscarriages. And otherwise, if patients are, these Google driven, because now we have a lot of patients who know more than us. So in those patients, ekdam dil khol ke write testing, because they got Google free, but they should pay somewhere. So that is one. But if they're not Google driven, do explain to them that I'm going to use a staircase pattern where I'll go slow and steady, and as we get it. But this is one area which sometimes I often feel, because say if I send out 100, maybe 1,000, I rarely see an abnormal report in those. And then you come across such articles which say, like, okay, it's just Robertsonian translocation, yevo. So I really don't know, ma'am. You throw some more light when it does. But when we do get it, this is interesting. Like, particularly like here, if you look at the first case, this is a very typical translocation over here. And same thing has happened here between 3 and 13. So at the end of the day, it does save a few souls. And particularly when we have these Muslim patients, consanguinity, wahan pe we are finding it definitely a lot more as a prevalence. But somehow then again I feel people who get married very early, they actually face lesser problems. But then The fun part is the educated mass is busy creating achhe din and we forget this. And those who aren't educated are enjoying this and creating not achhe din for them somewhere down the line. So eventually, I think our job is we have to stop this tear. And like I said in the beginning, for me, BOH is not just a disease. It's like being an optimistic healer. And all of us as a team, including our staff, because sometimes it does happen, like we don't train the staff and they're busy talking about children or whatever. And these ladies who are actually walking, they're quite tormented. And at the end, since I'm in Mumbai, this is a city of connoisseurs, I thought I should end with Pablo Picasso. I just don't know why somebody would pay 16 million for this. So maybe they have extra cash, even I can paint, because first I didn't know whether her dentures are there or she's got, thyroid problem. But then I realized, I saw the price of the photograph, this portrait, and I realized, Weeping Woman by Pablo Picasso. So at the end of the day, it's something like what I consider crap is of value to somebody, and same thing implies when we do BOH testing. Small and steady rather than slow and steady actually wins the race. Thank you very much for a patient hearing.
Thank you so much, Dr. Prashant, for such a fabulous insight on the pathology aspect when it comes to the screening. I think he has covered the entire spectra very well. Thank you so much once again. Any questions for him?
Any role of ANA or
Yeah, ANA actually, with the thrombophilia profile, we actually have it. So, no, ANA I would always put up, okay, it should be there. And do keep two things in mind. With ANA, if you're doing an ELISA, you're asking specific. I'll split it for two: ELISAs and immunofluorescence. With immunofluorescence, one big advantage you get is you get the pattern, and based on the pattern, you can further percolate a disease. Then you have the ANA blot if there is a confusion. But with ANA ELISAs, these indeterminate or intermediate, some kids call it, intermediate, some call it indeterminate. Don't fall for those values. Whichever lab you're sending out to, if they have a cutoff of 1 and you get 2, consider that to be diagnostically significant and just run a dsDNA after that, if you've asked a ELISA. On the IF front, one big request is anybody who's not running them with dilutions of 1:200 or they don't have Hep 2000 coated cells, and importantly, if it's just up to 2+, I think don't give it, that kind of importance. Clinical significance starts more from the 3+ and 4+ upwards. But ANA definitely, for me, I feel that's part of the thrombophilia profile, especially on the workup front. And we use fibrinogen also over there.
Right. I thought it's 1+ and beyond is significant clinically.
1+ I just consider as good as, you're trying to save your soul. So that's 1+ for me. But then 2+, you have to see what's your pattern. Pattern and yeah. Because somehow with 3+, I always feel it goes bang on with your diagnosis. And usually the gynec side, whenever we have seen it, it just starts from 3+. Whenever it's going to be involved. And plus the radio guys have also noticed a similar stream on the vascularity front. Any more questions?
Any more questions?
Yeah.
any particular reason why we find elevated D-dimer levels?
Have you ever done D-dimer in malaria? Some of these tests, it often happens like, for example, right now we were supposed to climb the stairs and this gentle lady thought that this gentleman can climb and this gentleman will take time. So, dikhao pe mat jao, that's what I say for a test. D-dimer somehow, that's why I never consider it. If you look at D-dimer, when do we use it more in the gynec side? When there's an abortion, there's a stillbirth. It would be preferred to be used there rather than being used for BOH. So D-dimer, and secondly with D-dimer, if you ever run 5 kids, you will find this huge variation. And the biggest problem is, especially with these carbon particle coated kits, you get a lot of false positives. Even with VDRL patients, they start blebbing up. So the higher the test, and personally, I've tried quite a few, and right now, are you a pathologist or a gynaec? Okay, like right now, especially for the D-dimer, I'm using only the Vidas systems. I'm very comfortable with it.
What kind of a value becomes significant for D-dimer?
In BOH?
How much
I
food?
won't say anything. It doesn't make sense actually. Stillbirth, yes. There definitely. But for BOH, I really wouldn't put D-dimer on the pedestal at all. Even pathophysiologically, it doesn't fit the bill.
SFLT is a blood test.
Yeah, it's a blood test. Yeah, absolutely a blood test. Yeah.
So what platform are you talking about here when it comes to marker? Because every platform has a different test set.
No, but right now, luckily, we don't have too many companies making this. So we're here, and then, like I said, even on the ELISA platform, whether you're doing an anticardiolipin, just see to it like whoever you're following, a baseline thing is if their titer is say 20 to 40 is indeterminate and more than 40, if you get something like 60 or 120, you're going to be bang on. But if it's 60 and it's 62, I don't know, it's quite a tricky issue.
Sorry, and the SFLT isn't to be done in the first trimester like you do the BHA?
Just like that.
At the same time, at that time.
And it really works out really well. And plus it gives you two things. It's as good as, ruling out the trisomies and everything. So that is also done. Plus you are prognosticating or rather predicting preeclampsia. And it's even much earlier. There's no clinical symptom at all. It's purely in the history that they go for it. And especially, these French fry women. So it helps there.
All right. Thank you.
Okay.
Let's felicitate Dr. Prashant for being there and enlightening us with information. Thank you so much.